Hi guys, welcome back. We shall now be talking regarding a valvular heart lesion, that is aortic stenosis. The first MCQ to be remembered for this condition is that it is overall the most common congenital heart valvular lesion. I would like to reiterate my statement, like you guys are comfortable with the fact that the most common congenital heart disease is perimembranous variety of VSD. Similarly, here I have said congenital heart valve lesion that we encounter in practice is aortic stenosis. In majority of series, it is a bicuspid aortic valve. In some series, it has been demonstrated to be even a unicuspid aortic valve, whereas normally it should be tricuspid. And on a view, on a actual view, it should look like this. We should be able to appreciate the three cusps of the valve very clearly, like I have shown here, three cusps very clearly delineated. But in patients who are having valvular aortic stenosis on a cross-sectional view, because these cusps are damaged, they could be scarring due to rheumatic process, they could be senile calcification. So you can see that I have shown that the valve is not gonna open properly as well as close properly. So lots of time you will notice that the damaged heart valves could be resulting in combination of two lesions together. That is, first it will not open properly, so aortic stenosis, it will not close properly, so aortic regurgitation could also be concomitantly present in the patient. I have shown a normal valve, a normal tricuspid aortic valve. There are three cusps that you can see of the aortic valve. This is a damaged aortic valve which will have a star shaped configuration. There is a problem with the cusps of the valve. This is damaged cusps of the aortic valve. So there are two problems which are occurring in this patient simultaneously, that is presence of AS and AR. Let's just quickly revise, why do you have valvular aortic stenosis? If you have a pediatric presentation, then it will be bicuspid aortic valve. Another MCQ that I can write while I'm writing this is that this is one of the common lesions that is seen with Turner syndrome. Turner syndrome, the common valvular lesion is bicuspid aortic valve followed by coarctation of aorta. And in Noonan syndrome, it is pulmonic stenosis. I'll write it down separately in a while, but I have explained that in other lectures also, so I just said it verbally. Do not be surprised if he says the word unicuspid aortic valve. That will even cause much more severe degree of symptoms developing in a patient, because the ability of the valve to allow the left ventricle blood into the aorta will be severely hampered. In old age group, this disease will mostly be degenerative calcification. It has been demonstrated in clinical studies that this degenerative calcification is associated with atherosclerosis. You see, atherosclerosis can involve abdominal aorta, root of aorta, coronary arteries. So atherosclerotic lesions can even involve the root of the aorta, including the area where the aortic valve is present. Atherosclerosis is anyway associated with development of calcification. So in these patients, we will be using a CT chest for evaluation. You see, in all valvular lesions, we say echocardiography is the best way. But for aortic stenosis, because there is a calcification in the valve, therefore nowadays we are using a CT chest for better evaluation of the anatomy related to the aortic valve. There will be a fibrocalcification developing in the valve thanks to the atherosclerosis component which is present in the patient. The textbook says that in these patients, there is a differentiation of fibroblasts into osteoblasts. Looks very surprising, but true. He says that as the disease progresses, there is a differentiation of the myofibroblasts or plain fibroblasts into osteoblasts, which start laying bone hair, or they start laying calcified tissue hair, and therefore calcification can be seen in this patient. So a very surprising manifestation of this patient is a bone matrix being deposited and calcification of the valve, and therefore we do not do a balloon valvuloplasty in these patients. If we will do a balloon dilatation, the valve cusps will break, like a biscuit will break into pieces, and those fragments will go into the brain, and that can result in development of stroke in the patient. So in pediatric age group, it is bicuspid aortic valve. In adult age group, it is a degenerative calcification. Coming to the third cause of valvular aortic stenosis, you need to remember rheumatic fever. You see, the problem with rheumatic is just like in mitral stenosis, it can cause a commissural fusion and the scarring of the valve cusps. The combination of the two can result in defective opening of the valve and presentation as aortic stenosis. The normal surface area of the aortic valve is in the range of 2.5 to 3 square centimeter, and if it becomes less than 1 square centimeter, we call it severe. So most patients of aortic stenosis are able to tolerate mild to moderate varieties. They usually present to us when the size becomes less than 1 square centimeter, and you could even be having a coexistent mitral and aortic stenosis. Coming to the fourth cause, there could be radiation as a cause. The radiation was given to a patient of Hodgkin's lymphoma for hilar lymphadenopathy. So mediastinal radiation for hilar lymphadenopathy secondary to Hodgkin's lymphoma, or I can say a patient was treated for breast cancer, modified radical mastectomy was done, but then there was a recurrence of the breast tumor, so radiation to the chest was given. So the fibrosis that has occurred in the aortic valve leaflet secondary to the mediastinal radiation can contribute to aortic stenosis. Very rarely the association can be with Schoen complex. There are two pediatric associations to be remembered for aortic stenosis. One is bicuspid / unicuspid aortic stenosis, and second is aspects related to Schoen complex. There are some components of the Schoen complex which are worth remembering because of the very peculiar names here. And the first association I wanted to remember is the word parachute mitral valve. Now, because we don't read about this terminology routinely, so I just thought I'll just invest about 30 seconds into this just to get the rare facts right. Though I think I would suggest you to focus on common things, no? Like they ask you what is the common presentation of valvular aortic stenosis. In internal medicine, it is geriatric presentation, calcification. Pediatric presentation, it is a bicuspid aortic valve. But yeah, if he says, then you should know that parachute mitral valve is an association of Schoen complex. And the second manifestation of this patient is also very surprising. He will say the word supravalvular mitral membrane. So there are two defects of the mitral valve, which I'll say once again. One would be parachute mitral valve and a supravalvular mitral membrane. And then there would be two problems in the aortic valve of the patient or related to the aortic valve of the patient. One is a subvalvular aortic stenosis. Though you read about subvalvular aortic stenosis and hypertrophic obstructive cardiomyopathy also, but in HOCM we usually talk about systolic anterior movement of the mitral valve, and here the associations of mitral valve are parachute mitral valve, supravalvular mitral membrane. The fourth manifestation of this patient is association with coarctation of aorta. So let's get the associations right. Remember the fact that the first thing that I taught you for valvular aortic stenosis was a cause by the name of bicuspid aortic valve. This is usually the common heart lesion that is seen in patients of Turner syndrome. And the second common lesion that is found in Turner syndrome is coarctation of aorta. I'll just put them in decreasing order of importance by putting 2-star versus a single star. Another association to be remembered is for hypertrophic obstructive cardiomyopathy, which is called as SAM. SAM would stand for systolic anterior displacement of the mitral valve, versus the word parachute mitral valve, which is already written on the slide before you. So to get both the words right, systolic anterior displacement of the mitral valve is a feature of hypertrophic obstructive cardiomyopathy, and parachute mitral valve is a feature that is related to Schoen complex with 4 aspects mentioned. 2 for mitral valve. What are the problems of mitral valve? A parachute mitral valve, very classical, and a supravalvular mitral membrane. Then is subvalvular aortic stenosis, which is associated with HOCM with only a left ventricular outflow tract obstruction, and then a coarctation of aorta. So these are some terminologies which I want you to remember. And now we will look at the presentation of hypertrophic obstructive cardiomyopathy. Coming to the clinical features of the disease, the gender-wise data would be that male patients are more likely to have this disease as compared to females, and the gender ratio is 2:4:1. Bicuspid aortic valve, which is mainly a pediatric presentation, has an autosomal dominant pattern of inheritance. So the same set of symptoms that I'll be just describing to you could be described in a father-son duo or father-daughter duo. The gene involved is called as Notch1 gene. For old age of these patients or the geriatric presentation of these patients, hypertension could be written. Please remember the fact that the hypertension that is described in a question of valvular aortic stenosis is not due to the valvular lesion, but is mainly because of the old age. So it's a comorbid risk factor that will increase the left ventricular hypertrophy of the patient and will put more stress on the patient, contributing to more angina. The clinical symptoms, whether a pediatric or a geriatric presentation, can be remembered by a triad by the name of SAD, where S would stand for syncope. This syncope would be coming on exertion in these patients and is mainly secondary to the fact that there is a fixed cardiac output. So if you expect this person to go upstairs with a backpack on his back carrying 5 kg weight or 10 kg weight, it would be difficult for these patients. So if this is an old man who's carrying a bag of vegetables because the lift in the building is not functioning, he can become unconscious. Alphabet A would stand for the angina component, which is secondary to the LVH, the left ventricular hypertrophy. And in these patients, because of old age again, there could also be triple vessel disease. So it's like a double whammy. Hypertension is worsening the left ventricular hypertrophy. The triple vessel disease is worsening the ischemia of the patient. So angina component in these patients can be fairly severe. And dyspnea is anyway a presentation of any cardiac lesion. And in these patients, that is secondary to the increased diastolic pressure of the left ventricle. Why the left ventricular end diastolic pressure is increased? Well, thanks to the hypertrophy component, the LV-ADP is more. So therefore, the left atrial pressure is also more. Therefore, there is congestion in the lungs and pulmonary edema will translate into dyspnea in the patient. Now, when you will examine this patient, the pulse of these patients will be relatively slow rising. The term that they will use to describe the slow rising pulse would be pulsus parvus et tardus. It can be written vice versa also, tardus et parvus. The basic point is that the English version of the pulse is that it is a slow rising pulse with a delayed peak. This is because there is a fixed obstruction present in the heart of the patient, but the ejection velocity of the heart is definitely increased in the patient. So you will read another terminology, anacrotic shudder. The meaning of the word anacrotic shudder is increase in ejection velocity. Let me just explain this in a different way to you so that this becomes a permanent memory. Let us assume this to be representation of the left ventricle of these patients, which is obviously going to get hypertrophied subsequently. And the orifice of the aortic valve in these patients has become progressively narrowed. The normal surface area of the aortic valve should be in the range of 2.5 to 3 square centimeter. You will say the patient is having severe valvular aortic stenosis when the orifice is less than 1 square centimeter. In some MCQs, he will write the word 0.6 square centimeter per meter square of body surface area because the pressure generated in the left ventricle is higher. So therefore, there will be a lot of turbulence when the blood goes out into the aorta of the patient. So there are two things that I'm saying. I'm saying amount of blood going out into the heart is lesser and slower, but the speed with which it is going, because there are two things, one is volume, second is pressure. So the volume is lesser, but the pressure is increased. Physics, no, the volume is lesser, the pressure is higher. So therefore, in these patients, anacrotic shudder could be present. So either he could write the word carotid thrill just to explain the radiation of the murmur in this patient, or he can write the word anacrotic shudder. But these are very classical words which would help you pick up this particular disease. The apex beat of these patients will always be displaced. It will be rather a double apical impulse, most of the time written. This is secondary to the hypertrophy, that the word would be double apical impulse. The character of the impulse will be heaving. The impulse will hit your finger and will lift up your finger. Please remember, in mitral regurgitation, I've said the word hyperdynamic impulse. That means the impulse is forceful, hits your finger, but doesn't lift your finger. But here, when you are feeling the apex beat, when you're doing a localization of the apex beat, the impulse will hit your finger with force and will also lift up your finger. So we call it a heaving apex beat with the displacement obviously to the left side. And this would be felt in both fifth as well as sixth intercostal space, so double apical impulse. Now let us look at the auscultatory findings of these patients. Coming to the second heart sound of these patients, because the blood will take relatively more time to go out of the heart, so the aortic valve of this person will close later. You see, please appreciate, a volume of blood going out of the heart is lesser, but even that lesser blood is taking more time than you and. Why? Because the orifice is small. So because A2 will be late, the gap between the two will become less than 30 milliseconds. So most of the time he will say the word narrow split second heart sound. Then the gap will become even more lesser, so it might even become single. And in lot of MCQs, he might write the word paradoxical split. Paradoxical split would imply that pulmonic valve has closed on time, but aortic valve will close after it. Normally, aortic closes before pulmonic valve. Here, the pulmonic will close on time and the aortic will close after it. So, paradoxical split. Then these patients will also be having a compensatory left atrial hypertrophy. So the atria of these patients will also be generating more force to push blood in a forward direction. Because of this atrial hypertrophy or the atrial kick, the patient will also be having a fourth heart sound. S4 will be given in the question. If he goes into heart failure, then S3, but initial presentation would be S4, and then we will talk about the murmur. The murmur of this patient will be a ejection systolic murmur. After S1, you have is a development of ejection click. In most of these patients, the ejection click will come closer to S1. That is because since the pressure of the left ventricle will start to increase, therefore, there will be a relatively early opening of the aortic valve. I repeat my statement once again. There is a higher pressure of the LV, the higher pressure will cause an early opening, so ejection click will occur relatively earlier. So most of the time the ejection click tends to, the loud ejection click in the patient can disappear with increase in severity. So therefore, in most of these patients, what happens is that the ejection click comes so close to S1 that the murmur tends to begin right from S1. Then it peaks in the middle of systole and then goes down. So the traditional word for this is a ejection systolic murmur, or is called as a crescendo decrescendo murmur. Most of the time in the exam, they will use the word ESM, that is ejection systolic murmur, for patients of valvular aortic stenosis. Now I want to bring to your attention another fact. In these patients, because of the higher pressure in the left ventricle of the patient, there will also be development of vibrations in the cusp of the aortic valve. You see, I'm saying two things. One, I am saying that blood is going out of the heart. So one, the noise that I'm talking about is due to the turbulence when blood has gone out into the aorta. Second, I'm saying when the blood is in the process of going out into the aorta, there can also be vibrations in the cusp. In these patients, the vibration of the cusp of the aortic valve will result in development of a sound which will usually radiate to the axilla. This can cause confusion with the murmur of mitral regurgitation, which is also a systolic murmur and radiates to the axilla. You see, I'm saying two things. One, I'm saying there is noise created when the blood is going out of the heart. And the second is the vibrations which are produced in the aortic cusp. So let's just write down the theory related to the two aspects that I've just said before you so that we can remember this better. First of all, I have said that the ejection systolic murmur of these patients will radiate to the carotid artery, and we are able to even feel the impulse over the carotid artery, that is called as carotid thrill. The vibrations which are going to be produced in the aortic annulus during the phase of systole are usually going to radiate to the axilla. This can easily cause misdiagnosis with mitral regurgitation, because the murmur of mitral regurgitation is also a systolic murmur that also radiates to the axilla. I want you to understand the fact that there is a terminology by the name of Gallawardine phenomenon, which you always read in literature of valvular aortic stenosis. What it basically means is that the murmur of aortic stenosis can radiate to the axilla as well. Now, I have said two things which I would like to clarify before you. One, I am saying that in aortic stenosis, the turbulence in the jet of blood, that is gonna radiate into the carotid artery because the blood is going into aorta and then into the carotid artery. Second, I am saying that the vibrations which are present in the aortic annulus are gonna radiate into the axilla. So there are two directions in which the murmur of aortic stenosis can radiate. That is, one, upwards to the carotid artery, and second to the axilla. And this that I've explained to you, that this can cause confusion with mitral regurgitation, because the murmur of mitral regurgitation is also a systolic murmur and it also radiates to the axilla. We can obviously differentiate between the two because other associated findings would be present, like mitral regurgitation would be having a pansystolic murmur. Here you are having ejection systolic murmur. The clinical presentation will be different. Mitral regurgitation is usually developing in scenario myxomatous degeneration of the valve, infective endocarditis. So obviously antecedental data is also to be considered, but considering the fact that when you are examining the patient, you are not aware at that point of time which etiology is responsible. So this fact has to be kept in mind. Let us now look at the ECG criteria for diagnosis of this patient. We shall now talk about workup of patients of aortic stenosis, and the first investigation to be done in the patient will be a baseline ECG. One of the highlights of the ECG of valvular aortic stenosis is that the S waves will be very deep in lead number V1, and when it comes to R waves in lead number V5, they will really be very, very tall. I'm just applying the rule here, that is SV1 and RV5 or V6 should be more than 35 to call it a presence of left ventricular hypertrophy. Let us now quickly count regarding the number of the large squares you can count here. So you can definitely count a substantially large number. I think the depth of the S wave itself is 25 millimeter. And then if you look at the height of the R wave in lead number V5, that's another 5 large squares, that is another 25 millimeter. So 25 plus 25 will work out to 50 millimeter. So you're really having a very big heart in these patients. So left ventricular hypertrophy is what you will definitely be able to notice. Another feature that is very visible in patients, especially in lead number V5 and V6, the lateral leads is T-wave inversion. So I'm also saying the word left ventricular strain pattern. What I mean by strain is that the oxygen demand of the heart is increased in the patient, and that is why a subendocardial ischemia or T-wave inversion finding can be noticed. When you will be doing a chest X-ray of the patient, it will definitely show a cardiomegaly and the cardiothoracic ratio will be increased. I will also be doing an echocardiography in the patient to identify the valve morphology. If the size of the valve is between 1.5 to 2 square centimeter, we will say mild. If it is between 1 to 1.5, we will say it is moderate. And if it is less than 1 square centimeter, then we will say that the patient is having a severe variety of valvular aortic stenosis. So it would be mild, then would be moderate, and then would be the severe variety. Now, because of the fact that lots of time the anatomy can be distorted by commissural fusion by calcification, so nowadays instead of echocardiography, what they're recommending is that the best way to identify a calcified aortic valve is a CT chest. So I would like to highlight like this, that for any valvular lesion or structural heart disease, you can easily answer as echocardiography. But for aortic stenosis, I would recommend you that if along with echo CT chest is also given, then CT would be advised, because that's what the textbook says, that the calcification and the distorted morphology secondary to calcification in adult age group or geriatric age group is best evaluated with help of a CT chest. Because a lot of these patients will also be having triple vessel disease due to old age, a coronary angiography should be done in these patients, especially to evaluate whether there is a requirement of coronary artery bypass grafting, because we can do both the procedures simultaneously, that is a aortic valve replacement plus a CABG, that is a coronary artery bypass grafting. When it comes to treadmill test in a patient, a lot of these patients may not be able to do it, especially severe aortic stenosis. We do not do a treadmill test. So what is the next best test after treadmill test I've taught you is stress echocardiography, where we can use dobutamine stress echo. But the problem in these patients is they are already hypertensive, and due to dobutamine the BP can increase very significantly. So I want you to remember the fact that treadmill test as well as dobutamine stress echo is not recommended for patients of severe valvular aortic stenosis. Why not in treadmill test? Why? Because they are having a low cardiac output or a fixed cardiac output, I would say. And when it comes to dobutamine stress echo, the concomitant hypertension will make it very dangerous to give dobutamine stress echo. That is why straight away a coronary angiography, or maybe we can do a nuclear scan in the patient, like a stress thallium in the patient. But the problem is, again, you might have to give pharmacological stress, and the pharmacological stress might not be tolerated by these patients due to concomitant hypertension. So straight away coronary angiography in these patients is warranted. Anyway, the patient is old age, so we know that there will be a substantial stenosis in the main coronary arteries of the patient. There could be various reasons why there could be death in these patients, and one of the important reasons of death could be heart failure. If syncope is present in a patient as a symptom, then usually if syncope has started appearing in the patient, the death will occur within 3 years. In fact, with syncope and angina appearing in a patient, the possibility of death of the patient within the next 3 years is definitely increased. On the other hand, if he starts having dyspnea also, that means there's a further decomposition, death will occur about 2 years. But if there is findings of congestive heart failure in a patient, then death will occur in 1.5 to 2 years. So I am again covering an MCQ here, that with which symptom highest chances of death can be seen in valvular aortic stenosis. Then I can say it's like this, that congestive heart failure is more dangerous than all of the other conditions because of the severe pulmonary edema component. So CHF will contribute to earlier mortality as compared to the other perspectives, and some of these patients can even have a sudden death. Sudden death is more common in asymptomatic aortic stenosis, whereas in symptomatic you are usually having a congestive heart failure and a decompensation that will develop in the patient. Coming to the treatment of patients of valvular aortic stenosis, what you will see nowadays is that in multiple choice questions, he might start using terminologies like stage ABCD. So stage A of valvular aortic stenosis simply means the fact that the person is having risk factors which are necessary for development of aortic stenosis, which could range from bicuspid aortic valve to a calcification in the valve in old age, but at the moment there is no narrowing of the valve. Stage B is said to be present when a person is having progressive narrowing of the valve from, let me say, 1 to 1.5, that would be moderate variety, or 1.5 to 2, that would be a mild variety of valvular aortic stenosis. If present in a patient, then I will say that the person is in stage B of valvular involvement. Stage C would be when the person is having severe aortic stenosis. Definition of severe aortic stenosis, I'll right at the bottom. That would be defined as transvalvular pressure gradient of more than 40 millimeter of mercury. What I mean by transvalvular pressure gradient is pressure difference between the left ventricle pressure and the aorta, and thanks to the hypertrophy of the heart, the blood goes out with more force, so the pressure gradient is more than 40 millimeters of mercury. This will also increase the ejection velocity 4 times the normal. You and me, the blood goes out of the heart at 1 meter per second, here will go out at 4 meters per second, and the size of the orifice is less than 1 square centimeter, or can be written as less than 0.6 square centimeter per meter square of body surface area. So any of these terminologies written in the question means severe aortic stenosis. You will say stage C when severe aortic stenosis person is asymptomatic, and stage D would be when you are having a person with severe aortic stenosis and the patient is symptomatic. When it comes to a symptomatic patient, the treatment of choice would be answered straight away as a transcatheter aortic valve replacement. I repeat my statement once again. For a person of stage D, which means that person is having severe symptomatic aortic stenosis, we will have to go in for a transcatheter aortic valve replacement. I'll just show you the image for it. You can see that we are deploying a prosthetic valve here. We are not removing the old heart valve, but we are deploying a new heart valve here. That would be called as a transcatheter aortic valve replacement, which is the in thing nowadays for that. I would put it like this: minimally invasive procedure that we are doing for these patients is a transcatheter aortic valve replacement. So for a symptomatic patient, stage D, it is TAVR. Now suppose he says person is stage C, that means he is asymptomatic. In asymptomatic patient, there must be presence of concomitant risk factors. So what could be concomitant risk factors that could be given in a question? The example could be like the person is having a concomitant triple vessel disease. There is a concomitant narrowing of the aortic valve of the patient, or there could be a decreased ejection fraction, like left ventricular ejection fraction is less than 50%. So though the patient is asymptomatic, there must be something extra in the heart for you to think in terms of a TAVR in the patient. So the treatment of choice for the patient is obviously going to be answered as transcatheter aortic valve replacement. The indications for treatment are not only the symptomatic severe aortic stenosis patient is to be treated, but even asymptomatic patient has to be treated, but asymptomatic only when there is a pressing need for it, like a low ejection fraction, concomitant triple vessel disease present in a patient, and coronary artery bypass grafting might even be required in these patients in a single sitting, which would obviously require the patient to be admitted for a relatively longer duration. Now, what is the treatment for hypertension of these patients? Then standard ACE inhibitors and beta blockers are to be given, but we have to keep a watch on the dosage because already these patients are having a limited cardiac output. So I don't want to be too aggressive in treating hypertension and end up with development of increased episodes of syncope in the patient. So hypertension is definitely to be treated, but obviously with a watch on the dosage. And statins are also recommended for these patients because a lot of them are having a triple vessel disease. They did a study to find that does statin reduce the progression of stenosis of the aortic valve in old age? Well, statins have not been shown to reduce the progression of the calcification of the valve. Why am I saying with calcification? Remember, right in the beginning I told you that atherosclerosis of the root of the aorta can involve the aortic valve, and therefore the aortic valve starts getting deformed, and later on there is a calcification because the fibroblasts differentiate into osteoblast and they start laying bone. So they did a proper control trial to see that does statin because statins anyway reverse atherosclerosis. Does it reduce the progression of the calcification of the valve? At the moment, the data says no, it does not reduce. So statins are being given to these patients not for reducing the progression of the calcification, but for the concomitant risk factor of triple vessel disease. And we can obviously calculate the Framingham heart risk 10-year mortality with the online calculator, which if more than 10% anyway, statins are to be given. Considering the old age, that would definitely be a high possibility in the patient. So medical management has limited role in these patients. Competitive sports, marathon running, joining a gym, etc. at this age is not recommended because the cardiac output is limited, and TAVR or transcatheter aortic valve replacement is the treatment of choice for patients with valvular aortic stenosis. So thank you so much for listening, and continue listening for further information. Keep on upgrading your knowledge because knowledge is power for you. Thank you.